Good morning, everyone. Respected chairpersons, my dear colleagues and friends. Well, today I will discuss about what's new in the management of dyslipidemia. As the chair told, we have a lot of medicines, the statins, the good old statins, to control the cholesterol levels. But we have newer medicines. We'll just see what are the new in dyslipidemia management. First, I will talk what's new in the guidelines of dyslipidemia. Then the newer molecules like bempedoic acid and PCSK9 inhibitors. So when you see the guidelines in 2018, the American guidelines, they put forward this new concept of high intensity, moderate and low intensity statin therapy, depending upon the amount of LDL reduction each dose of statins produce. And when see the ESC guidelines, ESC, they put forward the LDL targets depending upon the patient's baseline risk. The low risk patients, they've given the target of 115. But when you see the moderate risk patients, in the 2016 guidelines, it was to keep it less than LDL level less than 115. But when you see in 2019, they've made it more strict to keep it less than 100. High-risk patients, it was 100, which was reduced to 70 in 2019. And very high-risk patients, they have further reduced the level of LDL target to less than 55. So, as the cardiovascular risk increases, the need to reduce the LDL cholesterol increases. This is basically because of a lot of data showing that the lower the LDL, you tend to reduce the MACE. Now, coming to the Lipid Association of India guidelines, they put forward an expert consensus in 2020, where they've given a new classification and a new category, that is an extreme risk category. They've divided this into two, category A and category B. Category A is a patient with coronary artery disease with one or more than one feature of high risk group. And category B is patients with more risk, that is the patients with coronary artery disease with more than or equal to one features of very high risk group, or patients having recurrent ACS despite the LDL level of keeping LDL level of less than or equal to 50, and a patient with a polyvascular disease. So this is a new category which was put forward by the Lipid Association of India. And we'll see what they have set the target LDL for this category. For the extreme risk group, they have given that category A, the LDL goal should be less than 50, that is indispensable. And they have given an optional to keep an LDL goal of less than or equal to 30. And in category B, which is extremely high risk patients, having recurrent ACS, polyvascular disease, they have advised to keep an LDL level of less than or equal to 30. So the newer guidelines, the LDL targets is been very strict. So what's new in the lipid guidelines? The target has been made more strict. It is basically by the impact of the positive outcome in the Improve It and the PCSK9 inhibitor studies, where they have kept a very low levels of LDL and they found that they reduced the MACE with no significant increase in the adverse events. So now a patient with an ASCVD patient, the LDL target, according to the European guideline, it should be kept less than 55, and Lipid Association of India, it should be less than 50. The new category, that is extreme risk patient, is put forward by the Lipid Association of India, and the category B in the extreme risk, the target they have advised is to keep it less than 30. Now, what are the concerns regarding the newer guidelines? Do we actually attain these guidelines, these targets? Because it's been very strict guidelines to keep an LDL of less than 55 and to less than 30 is very difficult. And how to attain such low LDL levels? So this is an observational study conducted in Europe, in 18 countries in Europe, the Da Vinci study, where total number of patients enrolled were 5,888 with both primary and secondary prevention. They looked upon the impact of the newer guidelines, that ESC 2019 guidelines, and the LDL goal attained. Now, the subgroup analysis in this were very high-risk patients. They found that only 37.5% of the patients were on high-intensity statin. and just 18% attain the lipid goal as per the 2019 guidelines, and you take 2016 guidelines, 39% of the patients. So still very low levels of LDL goals attained in the real world scenario. So when do we consider non-statin lipid lowering agents? Because just with statin, it is almost impossible to attain such low levels. So when the target LDL is not attained, in very high-risk patients, ASCVD patients, polyvascular disease, recurrent events, patients with familial hypercholesterolemia, patients having statin intolerance. So what are the non-statin lipid LDL lowering agents currently available in India? We have the ezetimibe, the PCSK9 inhibitors, and bempedoic acid. So today I will be mainly talking about the PCSK9 inhibitors and the bempedoic acid. So we'll see the level of LDL reduced by these agents. The moderate intensity, we know it reduces around 30%, high intensity statin 50%, high intensity statin plus ezetimibe will reduce around 65%, PCSK9 inhibitor, there's around 60% reduction. When you combine a PCSK9 plus a high intensity statin, you get a reduction of around 75%, and PCSK9 high intensity statin plus an ezetimibe, you get a reduction of around 85%. So coming to bempedoic acid, it's a ATP citrate lyase inhibitor. The indications are those patients where LDL targets are not attained, especially in high-risk patients like mixed dyslipidemia, familial hypercholesterolemia, high-risk ASCVD patients. Patients having statin intolerance or statins are contraindicated. The dosage is 180 milligram daily. So I said earlier, the mechanism of action, it inhibits the ATP citrate lyase enzyme, which is actually a one step upstream the HMG-CoA reductase where the statins act. The half-life is 21 hours with 70% of drug is being excreted through the kidney. There is no renal or hepatic dose adjustment required, but there is no data for end-stage renal disease and severe hepatic impairment. So should be cautious in this subset of patients. When you see the randomized control trial for bempedoic acid, you have the clear harmony and the clear wisdom where maximally tolerable statin was given and the LDL targets were not attained. And the clear serenity and tranquility were the trials where statin was intolerant or statin was contraindicated. So the background therapy, they have only a low or very low or no statin therapy. When you see the clear harmony, there was around 16.5% reduction in the LDL on top of the maximally tolerable statin dose. And in clear wisdom, it was 15.1. Now the clear tranquility and serenity, you have around 23.5% reduction from the LDL, was reduction in the LDL levels. Now the clear outcome trial, which is the major trial with around more than 14,000 patients have been enrolled. This trial, the data is yet to come. Where they have looked upon the cardiovascular outcome of those patients where bempedoic acid was given. So they have looked upon the cardiovascular death, non-fatal MI, non-fatal stroke, and coronary revascularization. The trial is completed. Probably the data will be out in the March in the ACC conference. When you see the adverse events, the one thing which was a bit concerning was the hyperuricemia. It was been said that only a 0.8 milligram deciliter of uric acid level can be increased in the first 4 weeks when you start this drug. Another is 1.5% increase in the gout episode. So when you start this drug, it's always better to monitor the uric acid level of this patient. Now coming to the PCSK9 inhibitors, the pro-protein convertase subtilixin kexin 9 inhibitor. This is actually an enzyme produced primarily in the hepatocyte. It binds to the LDL receptors and causes them to degrade. So by inhibiting this PCSK9, we prevent the LDL receptor degradation. So more LDL is removed from the blood. So this is the mechanism of action of PCSK9 inhibitors. We have the two major agents, the evolocumab and the alirocumab. Evolocumab, both are subcutaneous injections. Evolocumab, you have 140 milligram every 2 weeks or 420 milligram per month. For alirocumab, it is 75 or 150 milligram every 2 weeks or 300 milligram per month. It comes in a pre-filled syringe, similar to what your insulin can give a subcutaneous injection. Now, the 4-year study, which is for the Evolocumab, where more than 27,000 patients, high-risk ASCVD patients were enrolled. The patients were on moderate or high-intensity statin along with plus or minus ezetimibe. And those patients with an LDL of more than or equal to 70 or non-HDL of more than or equal to 100 was enrolled into the two arms. And you can see the LDL levels, which are significantly reduced. By 4 weeks, there was around 57% reduction in the LDL level. By 12 and 24 weeks, more than 60% reduction in the LDL level. So there was a significant reduction in the LDL levels. And when you see the outcome, the primary endpoints like cardiovascular death, myocardial infarction, stroke, hospitalization for unstable angina and coronary revascularization, there was a significant reduction. The hazard ratio was 0.85 with a significant p-value. Also, the key secondary endpoints was also reduced with a significant p-value. But when you see the individual outcomes, the cardiovascular death, it was not significantly reduced, but the other three, the myocardial infarction, stroke, and coronary revascularization was significantly reduced. So it reduces the events, but when you see the mortality alone is not having a significant reduction. Another trial is ODC outcome for Evolocumab, was also having a similar data. The primary endpoint was significantly reduced. The secondary endpoints like the coronary events were significantly reduced. But when you see the death, the trend was favoring Evolocumab, but was not found to be statistically significant. Another issue is the cost with PCSK9. You can see the monthly cost for an atorvastatin or a rosuvastatin will be around 1,200. But when you see the PCSK9 inhibitor, the monthly cost of the treatment will be around 34,000 and the yearly cost will be around 4 lakhs. So this is a major issue in our country because most of our patients are not doesn't have the insurance, so it will be a cost burden for them to start with PCSK9 inhibitors. Just to summarize, the ASCVD or high-risk patients, if the patient saying start with high-intensity statin or a maximally tolerable statin, if the goal is not attained, can start ezetimibe. If still the goal is not attained, if your LDL target is less than or equal to 20% from your current LDL levels, then can start bempedoic acid. If it is more than 20%, the bempedoic acid, you expect around a 20% reduction. So if it is more than 20%, then you will have to go for a PCSK9 inhibitor. Maybe with more data, the bempedoic acid or PCSK9 may come above ezetimibe, but currently it is statin, then ezetimibe, then you can go for either two. The take-home message, the newer guidelines, more strict LDL targets. The ASCVD patients, the target should be less than 55 according to the ESC and less than 50 according to the Lipid Association of India. Bempedoic acid in LDL, when the LDL targets are not attained or the statin is intolerant, it reduces around 20% of LDL levels from on top of the statin therapy. PCSK9, around 60% reduction in the LDL levels. Thank you.
Thank you, Kiran, for simplifying the dyslipidemia and management. Now, we have no problems in combining drugs when it comes to manage hypertension, but we have a lot of resistance when we have to combine, because you have shown a combination of a high-intensity statin, ezetimibe, and bempedoic acid will give something like a PCSK9. But we hesitate, basically, possibly because we don't have any directives. At what point of time you should combine? I'm sure the LAI has given us some directive, but I'm not very sure. They are all consensus statement than guidelines. But I think it is time that we think very seriously about combination therapy in dyslipidemia management.
Yes, sir. Because actually the data is showing that the lower your LDL level, definitely the MACE is reduced. So you need to have a more strict LDL level. So for that, a combination is it's necessary. A single drug won't help you to attain such a low LDL levels. And even always it's a concern to keep an LDL of so very low. But I think the data from the PCSK9 inhibitor studies, they have shown that there is no much concern. Always we are concerned about the cognitive impairment, the hemorrhagic stroke, but the data is showing that there is no increase in such adverse events. So I think it is safe. The only issue is you will have to combine multiple drugs to attain such low LDL levels.
I have a question. It's not related to the topic. We have a patient whose LDL is 0. We repeated it again 0. You have any explanation?
We have some kind of deficiency syndromes we have seen, no? But then the adverse event, Kiran, again, you are also aware, in the PCSK9 trial, a subset analysis of more than 800 patients where LDL is less than 10 milligram. Practically, no. So I think we have some obsessions about the very low LDL and the your cognitive dysfunction, your excess incidence of intracerebral hemorrhage. But I think all the scientific data has shown that lower LDL level does not translate into very serious adverse events. Manjuran, sir, you have something?
The concept that the LDL should be 50 milligrams, around 50 milligrams, came from the observation that the aborigines, the newborn babies, and the monkeys which are closest to human beings have an LDL value of about 50 to 55. So that is why the concept came that 50 to 55 would be the most ideal and without any side effects. Many, of course, Prove It trial also showed that when they looked at the subgroup analysis, those patients who had less than 40 milligrams, they behaved the best. So there is a lot of evidence, but we do not know over a very long period there can be any impairment of some of the cerebral functions. So I don't know whether the whole thing should be taken up. And also, as you rightly said, reducing to 30 milligrams is an extremely difficult task. You have to make use of multiple drugs and sometimes very costly drugs. So I do not know whether how many patients will be able to continue with the medication which can actually bring down the 30 milligrams. I have found 50 is very acceptable. Patients accept it. It is reasonable and there is a scientific basis also.
What sir said is correct. I think the longest neurocognitive outcome data that we have is, I think, the Ebbinghaus data, which looked at the PCSK9 patients. Follow-up was for around 3 years. They looked specifically at psychomotor function and neurocognitive function. They did not find any impairment. In fact, it was the same. So maybe on longer follow-up, we might see.
People with an LDL less than 10, they couldn't find any abnormality or rather any adverse effect pertaining to a low LDL level per se. PCSK9 is prohibitively costly in India. Inclisiran is also going to be prohibitively costly. So then a combination of bempedoic acid plus statin, in high intensity statin plus ezetimibe, which as sir said may be equivalent to PCSK9 inhibitor plus ezetimibe plus high intensity statin, somewhere around 85% reduction in the LDL cholesterol. We don't have much studies. There is a clear outcome trial which recently published. I think bempedoic acid has also shown some benefit clinically. Otherwise, there were no outcome studies. Any update on that?
Concern during the 10-year data of the Fourier trial recently, you would have read it. There was some notion of an excess mortality. But then Mark Sabatha recently went again. It was a subset analysis cautioning people that,
that's a non-cardiovascular mortality.
Yeah, non-cardiovascular mortality may be higher in the long term. But I think it is.
Sir, is it due to the fact that people live long?
Absolutely. So it is possibly not the drug which is causing the adverse event, but otherwise. Thank you, Kiran, for that exciting talk.